Okay, good day, good evening, and good morning to everyone joining us from different parts of the world. My name is Bless Logo, and I am joining you today from Nigeria. I serve as the secretary with the TORG Global Education and Training Committee. And on behalf of the Operating Room Global and TORG Global Education Training Committee, I'm delighted to welcome you to today's global webinar. We are pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, surgical technologists, perfusionists, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multi countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, the Middle East, the Americas, or elsewhere, you are very welcome. Good morning to those joining early in the day, good afternoon to those in the middle of your day, and good evening to those of us joining later. We are grateful to have you all with us. We strongly encourage active participation throughout the section. Please use the chat box to introduce yourself by sharing your name, professional title, if applicable, and country. Post your question and comments at any time during the presentation. Our moderation team will be actively monitoring the charts and will bring your question forward during the discussion segments. For those joining a TORG section for the first time, the Operating Room Global TORG is a multidisciplinary professional platform representing over 260,000 surgical and pre-operative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties commentary and operates as a not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, 2RG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, and capacity building with a strong focus on safety, equity, and system strengthening. TRG is an international accredited continuing professional development provider recognized by the CPD Group, underscoring the quality and global relevance of our educational activities, and is supported by its academic and innovation arm. The Operating Room Global Center for Education, Research and Innovation incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnership. Our affiliated journal, the Operating Room Journal, is an open access, peer-reviewed international journal inaugurated in May 2015 to 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. TRG is also proud to host its own institutional review board, officially registered with the U.S. Office for Human Research Protection, reinforcing our commitment to ethical, responsible, and global credible research. TRG is driven by a volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance, Intersurgeon, and are listed with the Union of International Association and the Global Civil Society Database, reflecting our global accountability and reach. Once again, you are all welcome. Thank you.
Uh, Thank you so much, Blessing, for that excellent introduction, opening, and for welcoming our global attendees. In the high-stakes environment of the operating room, especially during complex gynecological surgeries, preparedness and expert coordination can literally mean the difference between life and death. Good day, colleagues, partners, and members of the operating room global community. My name is Emmanuel Tuishimre, and it is a great pleasure to introduce our speaker for today's session on emergency management in complex gynecological oncology surgery. We are honored to welcome Dr. Nigat Addis, a highly respected consultant obstetrician, gynecologist, and gynecologic oncologist. He serves as an assistant professor of obstetrics and gynecology at the University of Gondar, Ethiopia, where he is actively involved in clinical practice, surgical training, and academic research. Dr. Addis is a valued member of the Operating Room Global Institutional Review Board, TORG-IRB, and editorial board member of the Operating Room Global Journal. His contributions span clinical excellence, ethical research oversight, and scholarly publishing, reflecting his deep commitment to advancing women's health and surgical quality. With extensive experience in managing high-risk and complex gynecologic oncology cases, Dr. Addis brings practical insight into emergency preparedness, multidisciplinary coordination, and patient safety in oncologic surgical care. We are privileged to have him share his expertise with our global audience today. Please join me in extending a very warm global welcome to Dr. Nigat Addis. Thank you. Doctor, you are very welcome.
Thank you. Thank you, everyone. Good morning, good afternoon, good evening, all based on the time zone you are living. Thank you, Emmanuel, for introducing me. And thank you, dear COO, the Professor Adebusola, for inviting me or giving the chance to present on this topic. So I will proceed to the presentations. Yeah, am I audible? Just to confirm. Am I audible, please? Someone?
Yes, doctor, you're audible.
Okay. So, thank you. My topic is on My topic is on the emergency management in complex gynecological surgery. Okay, I made it a slide view. So this will be the outline of my presentation. We'll have a brief, just introductory terminologies. MDT or multidisciplinary team in the management of gynecologic cancer and potential and critical life-threatening complications in gynecologic oncology surgery, and the importance of IRAS in complex gynecologic oncology surgery in terms of prevention of complication. So, as an introduction, I think it is not complex terminology, though the task or the duty is much more complex. Yeah, gynecologic oncology is a subspecialty discipline under the gynecology and obstetrics stream, which deals with the diagnosis, treatment, follow-up, and prevention of female reproductive tract cancers. So it primarily focuses on the treatment and follow-up of vulvar cancer, vaginal cancer, cervical cancer, various types of uterine cancers, including gestational trophoblastic neoplasia, the ovarian cancer, fallopian tube cancer, and primary pelvic peritoneal cancers. So having the extension of the terminology, gynecologic oncologists or gynecologic oncology surgeons are experts in the surgical techniques, chemotherapy, radiation, and often providing comprehensive care and managing complex cancerous and non-cancerous gynecologic conditions. I brought these non-cancerous gynecologic conditions. For example, we can take a simple example of placenta accreta spectrum, because thus people or thus surgeons are experts in extensive pelvic tissue dissection, having their expert hand. They better be involved in the management of also non-cancerous, for example, placenta accreta spectrum management. They better get involved for better patient outcome. So studies show that patients with gynecological malignancies have better outcomes if treated by a gynecologic oncology surgeon. This is clearly stated on American College of Obstetrician and Gynecologists practice bulletin. So MDT in gynecological cancer treatment, due to the complex nature of gynecologic cancer patients, it is required to have a coordinated response from several departments to improve the patient's survival, reduce ICU admission, also their hospital stay. So most scholars over the globe agree on the multidisciplinary team involvement in the management of this complex cancer. Okay, so just to mention the bold ones, members of the multidisciplinary team in gynecologic cancer treatment, the main are gynecologic oncologists, the vascular surgeons, urological surgeons, general and colorectal surgeon, and also intensivists and anesthesiologists, anesthetists, as well as body imaging and interventional radiologists. There are many, but just to mention few, clinical and radiation oncologists are a member of gynecologic cancer treatment. I mean, the MDT member of gynecologic cancer treatment. So the surgical team should be proficient enough for performing this complex surgical procedure. And the anesthesiology and the ICU team is vital for managing septic shock, pulmonary embolism due to cancer embolus, or the complication following the extensive surgical treatment, also hemodynamic instability. The body imaging and interventional radiologists are very vital for perioperative or preoperative staging, as well as non-surgical options. And at times, hypogastric artery embolization is needed for massive bleeding. So, to mention one, radiation oncologists are very important to have continuation of adjuvant treatment modalities after this extensive surgical treatment. Okay, so complications in gynecologic oncologic surgery is mainly the massive hemorrhage and adjacent visceral organ injuries. In addition, lymphatic nerve injuries, infection, and febrile neutropenia, as well as thromboembolism and paralytic ileus are the commonest one. So, due to the nature of the surgery, surgical complications are inherent to gynecological oncology surgery due to extensiveness of the surgical procedure, anatomic alteration by the presence of huge tumor, the pelvic as well as abdominal cavity, and there are also patient-related factors. So frequency of surgical complications depends on various factors. For example, the type and mode of surgery, patient profile, and availability of surgical expertise. So in the emergency management, as I have said it before, multidisciplinary approach is needed so that life-threatening complications arising from this aggressive treatment or aggressive surgical treatment can be prevented timely. So among the complications, massive hemorrhage can arise from direct and inadvertent trauma to the vessel, as well as reactionary bleeding following extensive dissection. So the most important thing is it's crucial to anticipate the presence of such potential complications so that we can implement a systematic approach to manage it timely. So management options can be direct compression over the bleeding vessel or surface, then followed by identification and repair or ligation of the bleeding vessel as needed. The other treatment option may be hypogastric artery ligation, and in best setups, fibrin glue can be applied. What I can share you is about the hemostatic PAK. We have I have a real case scenario in low and middle income countries. In the past 3 years during my fellowship in Gynecological Oncology, we have several radical hysterectomies. That is a procedure for cervical cancer treatment. So in doing this procedure, we do extensive dissection of the pelvic lymph nodes. So the lateral and inferior limit of lymph node dissection is obturator fossa. So if you can see this in the pudendal canal, the nerve, the obturator nerve and artery entering to the pudendal canal. So this is the lower limit of the lower and the lateral limit of pelvic lymph node dissection. So while doing this lymph node dissection, we had, while harvesting these lymph nodes, we have injury to the obturator network of obturator vessels, the venous and arteries here. So as you know, the anatomy is very much difficult to access and repair the bleeding vessels. So what we did is putting a hemostatic PAK, and we removed it after 48 hours after the patient gets stabilized and the complication is over. So this is our experience from low-income country. What I can speak from Ethiopia, patient was successfully managed and treated with this conservative approach and discharged well. So the other complication is injury to the adjacent visceral organs. It may include injury to the urinary tract, such as the bladder and the ureter, GI tract, likely the bowel, mesentery, spleen, and liver may get injured or may be likely injured during extensive cytoreductive surgery of the ovarian cancer and endometrial cancer and the like. So this is due to the extensive resection of the cancerous mass, and the management depends on the specific organ involved during involved in the injury and other patient factors too. Okay. Okay. Yeah, depending on the organ which have the injury, the most common or most frequently injured organ in gynecological oncology surgery is bladder. Injuries may involve simply serosaltire. It may be small or wide area, muscular injury, and full thickness defect may be there. So the best option is to have it diagnosed intraoperatively. Yeah, this one can be done during cystoscopy confirmation after the procedure. But if this is missed, it may lead to post-operative complications like leakage, infection, and renal impairment. So management of bladder injury depends on the degree of injury. Yeah, serosal injuries can be primarily repaired, or as the bladder is very, very forgiving, it can be even left unrepaired. The serosa can be left unrepaired if the damage is too minimal. But if there is damage to the muscular layer and full thickness injury, having communication to the intravesical cavity, it may need watertight repair of the defect in 2 to 3 layered fashion. The other organ which may get injured during this extensive pelvic dissection is the ureter, and the potential sites of injury are mainly 4 at its center to the pelvis, near the ovarian vessels, while clamping, dividing, and ligating the infundibulopelvic pelvic ligament, and the third one is at the level of crossing the uterine arteries, and finally at the level of bladder insertion. So the mechanisms of injury may be kinking while making the knots, or transection, or thermal injury, and ligation. So this also, if it gets detected intraoperatively, the morbidity will be low. But if it is diagnosed late and once the patient gets complicated, the chance of having morbidity and mortality will be high. And the management options depends on the site of injury. If it is at the level of the mid-ureter, it can be managed with ureterostomy, with or without stent insertion, and the other is ureteroneocystostomy for distal ureter injuries. The other thing, if the repair is not possible, nephrostomy can be done. So the other organs which may be injured during extensive cytoreductive surgery are the rectum and colon, and the mechanism may include thermal injury, traction injuries while applying traction access to the pelvic cavity, the posterior pelvic cavity, and during sharp dissection as well. But the most common mechanism of injury is thermal injury, and it is usually unrecognized intraoperatively. So it may lead to delayed, it may require delayed intervention to prevent peritonitis and sepsis. So if we have high index of suspicion that there is a thermal injury to the bowel or rectal serosa and the other layers, we should be vigilant enough to detect it early to avoid peritonitis and sepsis. So management depends on the extent of tissue injury and presence or absence of contamination. So the options of management include primary closure or resection and anastomosis at the same time. The other alternative is fecal diversion and formation of temporary stoma, which can be closed later on after management of the early complication. So yeah, the surgical complications and other perioperative complications in gynecological oncology surgery can be prevented with meticulous anatomic identification and tissue dissection. We should ensure safety of energy devices by limiting collateral thermal spread, and intraoperative cystoscopy should be done for confirmation of ureteral and bladder integrity. So in the pre-op ureteral stent, insertion can be can facilitate tissue dissection so that the level of injury to the ureter can be minimized. So, as I have said it before, multidisciplinary team involvement, having joint surgery with urologists, colorectal surgeon, vascular surgeons may minimize morbidity following complication, or it may decrease the complication at all also. But last but not the least is the implementation of IRRAS. As we know, IRRAS has a role in minimization of complication, rapid recovery of patients, and resumption of normal activities after the surgery. So it's not the least, but the last thing to be considered is implementation of IRRAS. So even in complex surgeries, this IRRAS will reduce the length of stay and complication rates, and it should be implemented in different phases. There is no exemption or exception for gynecological oncology. Even they need this implementation of this protocol. So in the preoperative phase, intraoperative phase, and as well postoperative phase, IRRAS has to be implemented to have or to achieve optimum recovery of gynecologic cancer patients. So in the pre-op phase, patients should be counseled and educated about the type of procedure, anesthesia, potential complications, expected in-hospital stay, and resumption of chemotherapy or normal activities after the treatment. So information can be shared verbally with discussion with treating physician, surgeon, and it can be shared also with written documents like leaflets, and it can be also shared with video simulation. Before the surgery, the patient should have preoperative optimization. If there is anemia, it should be managed. If patients are smokers, alcohol abusers, they should cease it before the surgery, at least 1 month before the scheduled plan, and glycemic control. The glucose level has to be optimized for optimum outcome. The other thing is nutritional optimization. We should advocate to have a balanced diet as well as carbohydrate loading before the surgery. Solid diet can be given until 6 hours left for induction, and liquid diet can be taken up to 2 to 4 hours before the surgery. So regarding fasting and bowel preparation, the fasting time currently for solid diet, as I have said, is nearly 6 hours, as recommended by IRRAS, and for liquid diet, it can be as short as 2 hours. And currently there is no recommendation on utilization of mechanical bowel preparation. It was the previous or the traditional practice, but currently there is no recommendation on mechanical bowel preparation, even if bowel resection and anastomosis is planned. So choice of pre-anesthetic medications, we should avoid use of sedatives for anxiety, and we should implement or use multimodal analgesics. And we should have the clear plans before the patient is admitted for surgery. Thromboembolism prophylaxis should be considered for all patients, nearly for all gynecological oncology surgery patients. For example, vulvar cancer, we have to do extensive inguinal lymph node dissection. Ovarian cancer, if a staging laparotomy is to be done, there is a need to do pelvic and para-aortic lymph node dissection. And in cases of cervical cancer surgery also, there is a place for lymph node dissection. So thus patients are high risk to have DVT. So it's almost routine for all cancer patients in gynecologic oncology surgery to have DVT prophylaxis for the first 28 hours. 28 days, sorry. Regarding antimicrobial prophylaxis, it should be administered within 60 minutes of skin incision. And intraoperative considerations, short-acting analgesic should be considered so that we can avoid delayed weakening after the surgery. Multimodal and opioid sparing agents can be used, including magnesium sulfate. For example, magnesium sulfate can be used as 50 milligram per kg per dose, so that we can avoid opioid utilization. Opioids should be considered only breakthrough for patients who have breakthrough pain after the surgery in the post-operative period. Prophylaxis for post-operative nausea and vomiting should be administered, such as dexamethasone, ondansetron, and other antiemetic agents based on convenience and availability. Yeah, fluid management and maintaining EU volumia. Patient should be maintained as EU volumia. Even permissive oliguria should be utilized during the intraoperative period. Permissive hypotension, so that we can decrease or minimize the risk of bleeding, and should be maintained as normal temperature level. Normothermia should be maintained. And regarding the approach of surgery, as compared to open surgery, the minimal invasive surgery approaches, patients who are operated with minimal access surgery have faster recovery than the open approach. In addition to this, we should avoid utilization of tubes and drains whenever it's convenient. But if we utilize it, we should remove it at the earliest convenient time. And errors in the post-operative period. Yeah, patients after the surgery should start early oral feeding. It can be started 4 to 6 hours for liquid diet, and soft and previous regular diet can be started within 24 hours. Patients should be ambulating within the first 24 hours, and multimodal analgesia, potentially opioid sparing analgesia, can be used. And thus IV opioids can be used only for patients who have breakthrough pain. So thromboembolism should be continued for the first 28 days after the surgery. Catheter and drain management. Catheter can be removed within the first 24 hours. And routine placement of drainage tubes is not recommended. So regarding prevention of postoperative ileus, chewing gum may be utilized, or laxatives can be utilized, so that postoperative ileus can be prevented. Glucose control. Postoperatively, random blood sugar should be kept between 140 and 200, because hyperglycemia will increase postoperative morbidity. And monitoring should be done. What is done in the preoperative period, intraoperative period, and postoperative period until discharge. What is done based on the principles and practice of IRRAS has to be monitored, and this has to be assessed for its proper implementation. And this assessment should be done by the multidisciplinary team involving the surgeons, anesthesiologists, anesthetists, nurses, and other team members. So why RAS matters is for better outcome of the patients after the surgery, specifically in gynecological oncology surgery. It minimizes the rate of complication by 1/3. The hospital stay maybe minimized from 1 to 3 days, and the need of opioid utilization will be minimized by 70% at least. And in doing so, earlier return to adjuvant treatment or normal activity, safety, curative surgery will be achieved, and the cost of recovery or the cost of treatment for morbidity will be reduced so that they will have lower financial toxicity. So this is all I have for today. Thank you for your time and patience. Back to you.
Thank you so much for your invaluable words, Doctor. It is a pleasure to introduce Dr. Maria Khan, a consultant microbiologist, assistant professor, currently serving as the head of Pathology Department and chair of Hospital Infection Control Committee at the Peshawar Institute of Cardiology, Pakistan. Dr. Khan holds an MBBS degree, FCPS, M.Phil in medical microbiology, and a Master of Health Professions Education. She is also a board certified in infection and prevention control and holds multiple international certifications in biorisk management and biosecurity. With over a decade of specialized experience, Dr. Khan is a globally recognized expert in healthcare associated infections, antimicrobial stewardship, and infection prevention in high risk clinical environments. She currently contributes to an international level as a member of WHO Strategic and Technical Advisory Group for Antimicrobial Resistance 2024 to 2027 and serves as the editor for the Journal of Medical Microbiology. She also has completed advanced clinical training at the Mycology Reference Center, Manchester, NHS, and authored over 50 peer-reviewed publications with a strong focus on surgical site infections, outbreak preparedness, and infection control in complex surgical settings. Dr. Khan is an active member of the Operating Room Global Pakistan and continues to contribute to advancing safe surgical and perioperative practices globally. We are delighted to welcome Dr. Maria Khan to this session, where she'll be speaking about the silent threat, preventive invasive non-tuberculosis mycobacterial infections in cardiothoracic surgery.
Thank you. Thank you so much, Shruti. And good evening, everyone. Today, I'll be sharing how we've confronted the silent threat of the non-tuberculous mycobacterial infection, which is like a new standard for patient safety in cardiothoracic surgery these days. And we'll be looking at how these invisible environmental pathogens actually turned a routine surgical device into a global patient safety crisis. So what we've done to stop it, that we'll be discussing today. So objectives of my presentation will be, I'll start by framing what makes the non-tuberculous mycobacteria unique, and especially how it behaves very differently in cardiothoracic surgeries. Compared with the pulmonary infections, we usually learn about in NTM, which is very common. And next, I'll walk through how heater-cooler units, these heater-cooler devices function as reservoirs, and how their designs allow contaminated water to aerosolize and reach the surgical field. Then we'll cover the clinical side, why symptoms are so non-specific, and finally I'll tie everything together with practical aspects of the standard guidelines, the IPC practices, and to ensure device and safe medication use. So as we all know, non-tuberculous mycobacteria are opportunistic environmental organisms found commonly in water and soil, and they are very distinct from Mycobacterium tuberculosis because they are not typically transmitted from one person to other. Despite their very low virulence in healthy individuals, their ability to form resilient, these biofilms make them a significant threat when introduced into the sterile environment of a cardiac operating room. So we basically normally categorize them as either in slow-growing mycobacteria and rapidly, depending on how they grow in cultures. So this is the basic classification of NTMs. And this slide actually illustrates the vast diversity within the NTM genus, not just one or two organisms. There are over 170 species of NTM. And it specifically highlights how different species are linked to distinct clinical syndromes, because it can range from pulmonary disease to skin and soft tissue infections, like chronic lung infections, bronchiectasis, disseminated infection in AIDS. So this is a wide range of clinical syndromes in how they present. So basically, this is the NTM infections are associated with heater-cooler devices, sometimes which are used in cardiothoracic surgery, and they represent a very different epidemiological phenomena in these patients. And first, it was like the FDA took in late 2015, the FDA, actually the Food and Drug Authority, issued a major safety communication after identifying a link between these HCDs, specifically those used during open heart surgery. And there were serious bacterial infections caused by these bacteria. And most notably, they found Mycobacterium chimerae in these patients. So they actually recommended to adhere to manufacturer instructions for these HCDs and use only sterile or filtered water, direct these HCD exhausts away from the surgical field, and remove units with signs of contamination. We'll be discussing actually these points in detail, because how we can prevent these infections from these particular patients. So this is basically the timeline. How it tracks how a localized cluster of infections evolved into global safety crisis. First, there were initial detections in Europe, and then it took infections were also reported in US, and these eventually pinpointing the manufacturer's facility as the common source of contamination. So the first outbreak investigation at hospitals in Italy confirmed that invasive mycobacterium, these NTMs, infections were directly linked to contaminated heater-cooler units, and which were used in cardiac surgeries. And the molecular typing actually showed that patient isolates and the HCU, the water circulating in the HCU, environmental isolates, which we call them, were genetically related, supporting a single shared contamination source. So basically what this study highlights the need for strict device maintenance surveillance and improved engineering controls to prevent future these HCD associated infections. So these are the different medical device reports. The MTRs are basically the formal reports which are submitted sometimes to FDA whenever a medical device is suspected of causing some kind of injury or death or a significant infection. So these machines basically circulate water to control patient's body temperature. Actually, I'm talking about the HCD. And while the water doesn't actually come in contact with the patient, but the contaminated water can become aerosolized, turn into a fine mist, and blown into the open surgical field by machine, and they can then contaminate the patient field actually where the surgery is going on. So the main Stockit 3T were the devices which were, most of these 301 MDRs were associated with this machine, particular one, the first one actually, and they actually caused 12 plus deaths in due to these HCD contaminated worldwide. So in this study, actually, they summarized the FDA MDR, which were among 94 medical device reports were actually linked to HCDs, and valve surgery was the most common procedure, and about half involved implanted devices like LVADs and valves and vascular grafts, and these were the particular groups which were actually at highest risk. And this also, the data set shows that infections linked to these HCDs occur at multiple sites, not just the patient in wound infection, but they can also cause bloodstream infections, and also prostatic materials can get infected, and they can actually present years after their surgery, and sometimes months, as early as months. And the long median delay was diagnosis in these patients were actually 60 months. So the FDA actually recalls notice explains that contaminated water is sourced from these stocked T units were actually could reach the surgical field, and despite not being intended to contact the patient, and despite the laminar flow in the operation theaters, they can actually infect the surgical field. So the question arises, how does this NTM actually get into the HCD devices? So all heater-cooler devices are vulnerable to NTM infection, contamination basically, because their design allows biofilm to form in tubing and tanks, which routine cleaning actually cannot fully remove. Once established, these biofilms actually enable persistent bacterial growth and aerosolization during these device operation. So this slide actually shows this Mycobacterium chimerae contamination occurred during the manufacturing process of new HCUs, which multiple water sample testing positive before the device ever reached the hospital. So before the device were operational, these were actually contaminated in the industry. So this diagram actually shows how the contaminated aerosol from the HCUs can escape the water circuit and enter the operating field. This is actually the clinical presentation of these NTM. The patients can present with fever, fatigue, weight loss, shortness of breath, sometimes night sweats, just like tuberculosis. There can be splenomegaly, chorioretinitis, and the lab values are very, very much non-specific. They can present with anemia, lymphocytopenia, thrombocytopenia, elevated CRP transaminases, and elevated CRET. So in the manifestations further, the infections can present with either prostatic well endocarditis, vascular graft infection, or manifestation of these disseminated in the form of emboli, bone marrow involvement, splenomegaly, myocarditis, and osteomyelitis. So this is the data from our hospital in Peshawar. So there were actually pediatric series showing 12 confirmed cases, with over half developing a prostatic valve endocarditis and 42% actually presenting with disseminated diseases. Most of their blood cultures were positive for NTM, and the diagnosis was significantly delayed, a median between 350 days, and mortality reached actually 25%, reflecting the severity and late recognition of these particular infections. So delays actually occur because symptoms emerge years later and are non-specific, and cultures from slow-growing Mycobacterium chimerae, specifically NTM, are often not obtained early. So this is basically the guidance which CDC actually issued, and it outlines how to identify potential HCU-associated NTM infections. You can easily find them on the internet by combining these lab-confirmed invasive NTM cultures with key clinical syndromes. It actually directs hospital to review past surgeries involving cardiopulmonary bypass and flag patients with prostatic or deep tissue infection consistent with these NTM infections. So this is the slide actually showing three components needed to identify these possible NTM cases. First is lab assessment, then there's this clinical assessment, and the third element is actually the exposure assessment, specifically a history of surgery involving cardiopulmonary bypass. And this is the routine diagnostic for NTM, and it's actually a slow growing, as I've already mentioned, because the cultures actually takes weeks to grow, and identification is plus susceptibility testing add even more time. So this can take more than a month, and this delay means clinician must suspect the diagnosis early, long before this blood lab confirmation is available. So the lab lookbook alone misses many cases because AFB cultures are typically ordered only when risk factors are recognized. So therefore, active clinical case finding is essential to detect patients with prior cardiopulmonary bypass exposure who were never initially evaluated for NTM. So this is basically the graphic summarize how contaminated aerosol from HCUs can lead to infection in cardiac surgery, and especially those with prostatic material. It also highlights the long latency, difficult diagnosis, and the high mortality that make these NTM infections particularly challenging to detect and manage. And the antibiotic treatment is very complex, and it can have high mortality around 50%. So the treatment is very difficult because delayed diagnosis leads to widespread infection on prostatic material, where these biofilms actually protect NTM, and available drugs are mostly bacteriostatic with with very poor tissue these penetrations. So the therapy actually typically requires multi-drug regimens, such as it can be macrolides, these azithromycin, clarithromycin, rifampicin, ethambutol, and often amikacin. So this actually also summarizes how the patients actually clinically present. It can lead from deep surgical infection to disseminated one, and the diagnosis actually relies on high suspicion due to slow growth and very non-specific symptoms. So a clear summary of how our hospital actually rapidly activated the emergency command, traced potential exposures, communicated with the stakeholders, and removed or actually, sometimes we also relocated all HCUs to eliminate further aerosolization risk. So this is basically the flowchart which we actually followed, and how both patient samples and HCU samples should undergo actually cultures and sometimes molecular identification to confirm the NTM species outbreak. So the whole genome sequencing then links clinical and environmental isolates to determine whether these infections originate from HCU or not. So this is basically the slide. This also shows how it can present with different clinical presentations after positive cultures, and the clinical criteria of their history will be very much documented. And the key clinical clues includes atypical or delayed symptoms after any kind of prostatic material surgery or signs of these surgical infections. So this is another study in Zurich, this is actually a prolonged outbreak, which showed that Mycobacterium chimerae infections in patients who have undergone open chest surgeries with cardiopulmonary bypass and prostatic implants, actually they were linked to environmental this contamination. Environmental testing actually showed and the same organism in HCU and in airborne samples were same, and while the devices were running, linking this outbreak directly to HCU aerosolization. So this is actually a document by the UK, which actually risk of invasive was released by the Public Health England. It outlined guidance for identifying exposed patients, recognizing symptoms, and implementing safety actions to reduce infection risk. And this is also another study which actually shows a stepwise investigation across 5 hospitals, revealing these widespread actually NTM in contamination and confirming Mycobacterium chimerae in multiple HCUs through water sampling and whole genome sequencing. And the final analysis actually linked the strains from 2 hospitals, which were specific of subgroup 1.1 and 1.8, which actually reinforced the global connection between device contamination and postoperative infections. And this is also another case, shows a delayed infection appearing 17 months after valve and root replacement. And the initial symptoms were very non-specific, with very non-specific lab finding like pancytopenia. And despite treatment, the patient developed progressive renal failure and severe aortic insufficiency, which highlights why the treatment is very complex. And this is also another slide which actually shows the visible mist dispersing towards the surgical field by the HCU, highlighting the risk of NTM transmission during the cardiopulmonary bypass. And on average, it took 5.2, 139, 14.8 particles per minute in the surgical field at position off, on, oriented, and respectively. And the culture traces were positive for NTM. And this is also another literature which I found actually in July 2015. The Pennsylvania department also reported about a cluster of NTM infections among cardiothoracic surgical patients at one hospital, where the air samples collected at least 18 inches from the HCU exhaust vent during the operating room simulation were actually positive after 2, 3, and 4 hours after they were even off. Our lab testing at our hospital actually showed widespread NTM contamination found in decommissioned HCU nearby sinks, and even OR ice machines were positive. And air samplings also confirmed NTM growth. This is the scrub area, also their water were positive, and similarly the water in the HCUs. And this is also a timeline which actually shows how Pediatric Cardiac Center responded to these infections, starting with CDC warnings, and then there were enhanced sterilization, failed the FDA mandated discontinuation of these HCUs and prompting large-scale patient identification, family notification, and creation of a clinical task force and triage plan for these patients. And there were structured follow-ups, sometimes including a call center and targeted clinical assessment, ensuring monitoring of thousands of potentially exposed patients. This is also another image taken from Emerging Infectious Diseases Journal, where their article actually showed this picture, investigating extrapulmonary NTM in Pennsylvania in 2015, showing the internal tubing of the decommissioned heated cooler unit, showing a biofilm, and it was discovered after an outage actually growth this NTM in the culture. This is also another picture which shows that they can survive in the biofilms. This is also another effective control. This study actually showed how effective control requires biofilm targeting strategies, high disinfectant concentrations, and strict adherence to enhanced cleaning protocols to reduce microbial survival within these devices. And this is the water system, which actually shows this low flow rates and low residual disinfectant in water. Actually, if there is low chloramine at multiple water outlets, they're actually a risk factor. And specifically where the hot water system has a recirculating loop, and hot water are actually stored in reservoirs, which requires like prolonged flow times to reach the outlets, they are actually housing these NTMs. And this is another study which actually showed that there is no acceptable levels of NTM in HCU water tanks when you test water samples, as even the low level of contamination can aerosolize and reach the surgical feed. And this article actually emphasized that the strict maintenance, monitoring, and water quality control are essential because contaminated tanks pose a persistent and preventable infection risk. This is the infection control hierarchy, which we also followed in our hospital. And this actually shows that the infection control measures are prioritized, starting with engineering controls that actually tackle the risk at the source, which includes placing HCUs outside OR, and the duct exhaust should be external, use sterile filtered water, avoid recirculation of water in these systems. Another is the maintenance and sampling. This is daily draining, weekly disinfection, and routine NTM cultures are recommended. Apart from routine water cultures, we should specifically order for NTM cultures in water as well. And because they are very critical, because lapses here quickly increase a risk of these NTM infections. And for the administrative control, support the system by ensuring we should do staff training, surveillance, active surveillance, and consistent incident reporting. Together, these all three layers create a comprehensive defense against this NTM infection contamination in surgical environment. And this is a very good description. This table actually shows that these interventions, if we take them in the hospitals, specifically for the cardiac surgery ones, they actually, if you implement them to reduce, it actually shows that the figures are actually reducing the healthcare-associated NTM infections, especially linked to water system and heater-cooler device. It actually highlights the need for sterile water in all high-risk patient care activities and strict adherence to HCU manufacturers' disinfection protocols. We should be regularly following these IFUs for each and every machine which is used in the OR. It actually emphasizes the role of epidemiological surveillance as well. Environmental measures like including flushing stagnant water, monitoring temperatures, measuring disinfectant levels in water, and minimizing plumbing dead legs. And the facilities with persistent NTM issue may require point of use filtration and biofilm culturing to identify hidden contamination sources. And these are the key mitigation steps which should be taken for HCU devices. And just another challenge for our study was that the case finding is quite difficult. The communication is very important for these patient tracking, and the risk assessment and mitigation are quite a big challenge. So other challenges might include uncertain epidemiology, chronic underreporting, and it actually highlights the operational challenges, notifying exposed patients, obtaining consent, and assessing other potential pathogens in HCUs, particularly Legionella and other bacterial and fungal infections. So this box is just a summary of mitigation measures, which we already discussed in previous slides. And this table also summarizes the practical high-yield measures to reduce HCU-associated NTM risk, because this is quite a novel thing, actually, which we experienced in our setup in the past few years. If you take a strict adherence to IFUs of these machines, specifically the HCUs, and water safety of aerosol control and device monitoring, that's a key to prevent these infections. This is also another, we have summarized all of this in this diagram. And the take-home message for this presentation for today is that if we bridge the lab sciences and infrastructure, we actually can protect our vulnerable children and turn our experience into a national template for safer cardiac surgery. And prevention is required system thinking, actually, and combining engineering, clinical vigilance, and administrative controls can actually have a good impact. This is the conclusion. If we have the incidence is likely quite underreported in our part of the world, and it's very difficult to culture these bacteria, and lack of awareness can be in clinicians, and managing these patients are quite difficult. So cardiac thoracic surgery awareness is critical to implement short and long-term solutions to this emerging public health concern. Thank you for your attention, and I'd love to hear your insights as well, because we have a really wide range of professionals, OR professionals from all over the world. If they have experienced this infection, actually, NTM is a risk for your institution as well if you are if you have these HCUs in OR. And thank you for your attention and for supporting our research and strengthening global health security. Thank you, TORG team. And these are the references for my presentation. And I'll be really happy to take any questions if there are.
Thank you so much. Thank you so much, Dr. Maria, for that impactful presentation. Thank you so much. And also, we want to say thank you to our speaker, our first speaker too. So this is time for question and answer. Please, if anyone have any question, please do well to write it in the chat box, or you can raise up your hand, and we'll permit you to ask your question. Okay, I have a question here in the chat box. Okay. I have a question here in the chat box. The first question says, how often can the operating room ventable clean directory placed in the operating field to prevent MTF? Okay, and this question is yes, from Anne Maria. How often can the operating room theater vestibule clean directory placed in the operating? Please, can you make the question more clearer? Is there any other person that have any question? Okay, I have a question here for Demike Fenty. The question is, how often should we do fumigation in the operating room?
Blessing, I think this question is for me
Yeah.
because I was talking about the IPC practices of OR. So this is no recommended like routine for example, periodic. If you say once a day or twice a day, it all depends on your traffic, OT traffic, and ideally, if there is any infected patient which is operated in the OR, that is. When you do, and there is a risk of MRSA infection or any kind of aerosolized infection, which is actually the patient is. So you should do fumigation then. But there is no specific like one doesn't fit all. One size doesn't fit all for every OR.
Okay, thank you so much. Another question from the chat box. The question is also asking about fumigation after HCV positive cases. Then, fumigation, how often do we do fumigation after HCV positive cases?
Yeah, so HCV positive cases, actually, this is a bloodborne infection, sometimes STD also. So this is HCV, this is not strictly recommended to do any kind of fumigation for HCV cases. Just normal, if you practice normal standard universal precautions after every surgery, like cleaning the surfaces and doing the patient should be properly, like you have to wear your PPEs. That is the recommendation. There's no strict recommendation after doing fumigation after HCV cases. And there's also another question, Blessing, how often can the AC vent be cleaned? So it depends. Your biomedical and your HVAC engineers are actually really the professionals, actually the right person for this question, because they know when routinely how they have to clean their AC vents. So depending on how dirty they are and what's the manufacturer recommendation for these AC vents, that is actually answer to this question. So another question is why we don't do fumigation at regular interval in OR. It all depends on your facility and your policies of your hospital, because it's routinely like if you're not recommended every time like on daily basis you have to do any kind of fumigation. It all depends on the traffic in your OR, and it depends on what kind of patients you are dealing in OR. So it all depends on that, and it varies with every institution. It's not specific for one. If I'm doing twice a month fumigation in my OR, that same practice cannot be applied anywhere in other hospitals of the same country even. So what chemical is standard for fumigation in the OR? So actually what we do in our hospital is that we do hydrogen peroxide fumigation. That's the chemical which we use in our fumigation machine. Another question is, which antiseptic solution is work great for damp dust? So damp dust is actually, you have to clean first. There is no direct disinfection should not be done on any surface. You have to clean the surface first and then do disinfection. Blessing, are there any other questions?
Okay. Oh, so sorry. Okay, I can see there is no more question. Okay. Okay, another question is which an antiseptic solution is work great for dam dusting? You've answered that. Another question is can it be used for gangrene? Gangrene?
Actually, for gangrene, if Dr. Nigat can actually, because he's a surgeon, he can probably answer that question well.
Okay. Dr. Adidas, please can you answer the question? Okay.
And show
Thank
me
you.
the question first. Sorry.
Okay.
Actually, they are asking which antiseptic solutions are used for gangrene.
Yeah, for gangrene, there is a specific management what the surgeons recommended. Yeah, the dead and devitalizer tissue has to be removed. And the level of gangrene is the limit for the definitive treatment.
Okay, thank you so much. Okay,
Okay, another question. I can. Okay, the another question is fumigation same as misting? So fumigation actually is a kind of a misting, but depends on what kind of fumigation are you using. Actually, the fumigation can be in the form of in the COVID, which we did actually was the chlorine misting or fumigation. But another fumigation which actually is happening in our hospitals is actually hydrogen peroxide fumigation. Previously, it was formaldehyde fumigation, which is actually banned now. It's outdated. We don't use that these days. And pesticide actually misting and fumigation is also similar. It depends on what's the size of particles which are released from these machines, which are fumigation machines. So they can be as small as aerosols, and they can be larger than droplets. And if there's another question, if fumigation is not available, can we use any other alternatives? Yes, actually, fumigation machines are quite expensive, and not all hospitals and LMICs can afford them. So basically, what we do is that we can do surface disinfection. We actually stress more on surface cleaning and disinfections because it's more active and it's more appropriate. That is actually what we do if we don't have these fumigations. So surface disinfection and cleaning is the key for this. We do not use formalin these days because it was carcinogenic, and it's also quite irritating to by inhalation. So we don't use formalin fumigation these days, and its recommendation is mostly either it can be hydrogen peroxide, peracetic acid, or any other chemical, which is safe actually.
thank you so much. Thank you so much. Move over to our closing remark.
All right, so on behalf of the Operating Room Global, I would like to sincerely thank our speakers for their valuable insights and our participants for joining us from different countries, time zones, and professional backgrounds. We recognize that many of you participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and perioperative care in your local settings. Please feel free to share any key lessons from today's session within your terms, institutions, and professional networks as part of strengthening safe and effective practice globally. We encourage you highly to stay connected to the TORG through our upcoming webinars, training programs, and research activities, which are basically published on our website and across all our official platforms. To receive your TORG accredited training certificate, please note the following. Immediately after the session, the evaluation and certification form will open in the browser on your device, and it will remain active only for 24 hours. Certificates are issued within 5 to 7 working days after successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TORG membership ID. Once again, thank you for being part of the TORG Global community. We wish you a safe, productive day and even evening ahead, wherever you're joining from. Thank you once again for joining us, and we look forward for supporting your continued professional development with the Operating Room Global. Thank you.
Thank you, everyone.